So the learning objectives are, as I've alluded to already, we'll discuss very specialist disease-specific problems related to the skull base and their endoscopic management largely. The invited faculty are and will be worldwide experts in their respective fields. The idea is very focused and current evidence-based learning from people who are very, very busy in their clinical practices, seeing lots and lots of these sorts of patients and cases, and that they're able to share their knowledge and expertise. And the specific purpose of this particular platform is to discuss challenging situations, management situations, dilemmas, and to be able to share expertise in these areas. And also currently, COVID-related challenges in management. And I'm sure that you'll have some of those questions yourselves. And what we've asked each of the speakers to do is to really sort of divulge what their thought processes are on the management journey for these very challenging group of patients, and what their specific learning points are for the areas that we've asked them to talk about, and how they might have done things differently had the situation been different. So just to set the scene then, a couple of slides, so one on chordoma, one on chondrosarcoma, before we lead into the first presentation with Paul Gardner. So chordoma is a rare malignancy involving the bones of the skull base and spine. It comes and sits within the sarcoma family of tumours. Very rare, okay, so only 3% or so of the tumours that we see in the skull base, and usually slow growing. The difficulty arises because of where the tumour grows and critical structures that sit in the vicinity, so access, dealing with the tumour, and then reconstruction of the challenges that the teams face. Recurrences can occur at the same site as the primary tumour, and up to 30 to 40% may eventually metastasise to other parts of the body. Very rare tumour, okay, so 300 per year across the US and 700 per year across the entirety of Europe, so very rare tumours. And there does tend to be a male preponderance, so 2 to 1 in favour of males, and chordoma particularly tends to present in younger patients. Chondrosarcoma, again very rare, so 2% to 6% of skull base neoplasms, may be slow growing and localised or highly aggressive with metastatic potential. The bones of the skull base, when they form, mature predominantly by endochondral ossification, and intracranial chondrosarcomas are thought to develop from chondrocytes within rests of endochondral cartilage present within the skull base. The majority are located off the midline, so if you tend to see a tumour that's located off the midline on scanning, it's more likely to be a chondrosarcoma, and for us it's usually involving the petroclival junction, although it can sit within the nasal cavity at the base of the skull for other rare types of cases. Most arise de novo, but they can be involved in syndromes, and again the anatomical location makes them difficult to treat, again with a male preponderance of 2 to 1.